Every 3 seconds, somewhere on this planet, someone is diagnosed with dementia. By the time you finish watching this video, more than 400 people will have heard the words "it is Alzheimer's" for the first time. Worldwide, 55 million people are living with dementia right now, with another 10 million new cases added every year. It is the seventh leading cause of death globally, but for adults over 60, surveys show it is the single most feared diagnosis on the planet, more feared than cancer, more feared than heart attack, more feared than stroke. The part nobody tells you clearly enough. The 12 months before a dementia diagnosis are not silent. The brain gives off very specific, very consistent signals during that final year. Almost nobody has been taught what those signals look like. By the time most families finally recognize what is happening, the disease has crossed from a stage where it can be slowed, sometimes halted, into a stage where it can only be managed. If you want health information explained in plain language with no drama and no sugarcoating, subscribe to this channel and hit the like button. I am Dr. Kevin Wang, a physician specializing in geriatric medicine and longevity research. And my goal is to reach 100,000 subscribers so more families can learn what I'm about to teach you. I also share extra checklists and screening guides you can keep on your phone. The link is in the description below this video if you want to grab them. Dementia is not just you were fine, you forgot a name, you ended up in a nursing home. In most cases, dementia is the predictable endpoint of a brain that has been quietly degrading for 1 to 2 decades. If something is predictable, it is at least partly preventable. That is the whole point of this video. When people say dementia, they are talking about a category, not a single disease. Alzheimer's disease is the most common form, accounting for 60 to 70% of all cases. Vascular dementia is the second, caused by small repeated injuries to the brain's blood supply. Then Lewy body and frontotemporal dementia. They have different biology, but the 12-month prodrome looks remarkably similar across all of them. That is what we are going to focus on today. To understand why every month of that window matters, you need a feel for how demanding your brain is. It weighs about 1.5 kilograms, around 2% of your body weight, but uses 20% of the oxygen you breathe and 25% of the glucose in your blood. 86 billion neurons, each forming thousands of connections to others. The most metabolically expensive organ in your body, and it never gets a day off. Most people miss what I'm about to say. For dementia symptoms to suddenly appear, the groundwork usually took 15 to 20 years. Abnormal proteins called amyloid beta and tau have been slowly accumulating. Synaptic connections have been disappearing. The hippocampus and entorhinal cortex have already lost up to 30% of their volume by the time anyone notices a problem. This is not a switch that flips overnight. It is the final visible stretch of a long, silent process. In medicine, that final 12-month window before diagnosis has its own name. It is called mild cognitive impairment, or MCI for short. Mild because it's not yet full dementia. Impairment because cognitive function has measurably declined below what is normal for the person's age. Roughly 15 to 20% of adults over 65 have MCI at any given time. Around 35% of them will progress to full Alzheimer's within 5 years. The rest either remain stable or in some cases improve. That is what makes the MCI phase so important. It is your 12-month window. The period where the underlying disease is active but still treatable, where lifestyle changes still meaningfully slow progression, and where new disease-modifying medications now exist that can change the trajectory entirely. Those 12 months are not a death sentence. They are an opening. The problem is almost nobody uses it because the symptoms are subtle, intermittent, and easy to explain away. Each of those symptoms is your brain sending a clear message. I am in trouble. Catch me now while you still can. I want to walk you through the 6 big red flags that show up in that window. For each one, I will explain not just what it looks like, but exactly what is happening inside the brain when it appears. The first warning sign is difficulty with familiar multi-step tasks. Tasks the person has done thousands of times before. Operating the television remote, using the microwave, following a recipe they have made for 40 years, paying a stack of bills. These are routine, automatic, overlearned behaviors that suddenly become confusing. In a healthy brain, these tasks are handled by procedural memory and executive function, coordinated through the prefrontal cortex and basal ganglia. You do not think about them. They run on automatic. When dementia begins to affect the prefrontal cortex, the brain loses the ability to chain steps together. Step 1, pick up the remote. Step 2, press the power button. Step 3, find the channel. Each step in isolation is still possible, but linking them in sequence becomes effortful. This is not the same as struggling with new technology you have never used before. A 75-year-old learning a new smartphone is going to struggle, and that is normal aging. The red flag is when someone struggles with a device they have been using competently for years and suddenly cannot. That is a different signal. That is the prefrontal cortex starting to fail. In clinical practice, when family members notice this for the first time, they almost always explain it away. He is just being lazy. She's overwhelmed. He is depressed since retirement. The reality in many cases is that the brain region responsible for sequencing daily tasks has begun to atrophy. If this is happening at least once a week with tasks the person used to do without thinking, it deserves a proper evaluation. The second warning sign is repeating the same question, the same story, or the same statement within a short time frame, not the occasional repeated story at Thanksgiving. The red flag is repetition within minutes. Asking what time the appointment is 3 times in a half-hour drive. Telling the same anecdote twice in one phone call. Asking what is for dinner 40 minutes after dinner has been served. This sign tells you that short-term memory consolidation has begun to fail. The hippocampus, the small seahorse-shaped structure in the middle of the brain, is responsible for laying down new memory traces. It is also the first brain structure attacked by Alzheimer's. When it begins to fail, the person can still ask the question, they can still understand the answer, but the moment they look away, the entire exchange disappears. So the brain, doing its job, asks the question again. What is so painful about this sign is the patient often does not realize they are repeating themselves. From their perspective, they are asking the question for the first time. When a family member corrects them, they become confused, sometimes embarrassed, sometimes angry. The repetition is not behavior they can control, it is a structural failure. The cutoff is this. If a person is repeating a question or story more than 2 or 3 times within the same conversation or within the same day, on a regular basis, that is well outside normal aging, and it warrants a formal cognitive screening. The third warning sign is the one I want you to pay particular attention to. Getting briefly lost or disoriented in familiar places. Missing a turn on a route they have driven for 30 years. Wandering through a familiar shopping mall and forgetting which entrance the car is parked at. Standing in their own kitchen trying to remember which cabinet the coffee mugs are in. These episodes usually last seconds to a few minutes, then resolve. The brain region responsible for spatial orientation is the entorhinal cortex, which sits right next to the hippocampus. It contains specialized cells called grid cells and place cells that act like the brain's internal GPS. The entorhinal cortex is the first region affected by Alzheimer's pathology, even before the hippocampus. Tau protein begins to accumulate there years before any other change is visible on a scan. When the entorhinal cortex starts to fail, the brain's spatial map degrades. Familiar environments stop feeling automatic. The person has to consciously think about where they are. And in moments of stress or distraction, the conscious effort is not enough. They get briefly disoriented in a place they should know by heart. Doctors have a specific term for this: topographical disorientation. Studies have found it can precede a formal diagnosis by 12 to 24 months in roughly 70% of cases. Patients with early Alzheimer's are often most comfortable in their own home because they cope by sticking to well-worn routines. A trip to an unfamiliar restaurant or a vacation hotel suddenly reveals the spatial deficit, and family members notice the person becomes anxious in any new environment. That is the entorhinal cortex telling the family what the patient cannot yet articulate. The fourth warning sign is in the area of language, specifically word substitution. Not the occasional tip of the tongue moment when you cannot quite recall a friend's last name. That is normal. What worries neurologists is when the person substitutes a wrong word for the right word, often using a vague descriptor in place of the missing noun. The thing you cook in instead of the pan. The clicker instead of the remote. The white machine instead of the refrigerator. The little stick instead of the pen. The language centers of the brain, primarily in the left temporal and parietal lobes, contain a structure called the temporal pole, which acts as a kind of name dictionary. When you see a refrigerator, the visual recognition system sends the image to the temporal pole, which retrieves the word. In the prodromal phase of Alzheimer's, the temporal pole begins to deteriorate. The person can still see the object, they can still describe its function, but the precise word is no longer accessible. The clue is not the occasional missing word, it is the pattern. Several missing words in a single conversation. A growing reliance on circumlocution, talking around the missing word with phrases like that thing or you know what I mean. And the missing words tend to be everyday nouns, not unusual ones. Forgetting the word for an obscure animal at the zoo is normal. Forgetting the word for spoon at the dinner table is not. The fifth warning sign is personality change, specifically a flattening or withdrawal. Loss of interest in hobbies the person has loved for decades. A retired teacher who stops reading novels, a lifelong gardener who lets the garden go. A grandparent who used to call every Sunday and now does not pick up the phone. This is not depression in the usual sense. The person is not sad about it. They have simply stopped initiating. The clinical term is apathy. It is one of the most under-recognized signs of early dementia because it does not look like a memory problem. It looks like the person is slowing down, just being lazy, just losing interest in retirement. Family members often misread it as depression and request an antidepressant, which usually does not work because the underlying problem is not mood. The brain region responsible for initiative, motivation, and goal-directed behavior is the anterior cingulate cortex, which sits at the front of the brain just above the corpus callosum. It is part of what we call the salience network, the network that decides which thoughts and impulses are worth acting on. When the anterior cingulate begins to atrophy, the brain loses its ability to convert intention into action. The person may still think I should call my daughter, but the thought no longer triggers the behavior. Days pass, weeks pass, the person is not aware they are pulling away. What makes this sign so dangerous is it accelerates every other sign. A person who has stopped doing crossword puzzles, stopped exercising, stopped socializing, is losing the cognitive reserve that protects against further decline. Apathy and withdrawal feed the disease. Engagement and stimulation slow it down. If a family member or friend over 60 has visibly lost interest in things they used to care about, and you cannot explain it with grief, medication, or a specific life event, treat it as a possible early sign. The sixth and final warning sign is the one almost no family recognizes for what it is: loss of insight. The medical term is anosognosia, which literally means a lack of awareness of a disease state. It is the brain's inability to recognize its own decline. Picture the dynamic. A family member starts noticing the repeated questions, the missing words, the burned dinners. They gently raise it. The person reacts with denial, sometimes irritation, sometimes outright anger. I am fine. You are the one with the problem. My memory is sharp. The family member feels gaslit, exhausted, and begins to wonder if they are imagining things. What is actually happening is the brain regions responsible for self-awareness, primarily the right inferior parietal lobe and the right insula, have begun to lose function. When they degrade, the person genuinely cannot perceive their own cognitive decline. From their perspective, everything is fine. The denial is not stubbornness. It is biology. This sign is one of the most painful in clinical practice. The family is right. The patient is sick. The patient cannot see it. By the time the family forces an evaluation, the disease is often well into the prodromal window and sometimes already past it. Healthy older adults with intact insight are usually curious about their own cognitive changes. They want to know. They get themselves screened. Patients in the prodromal phase often actively resist screening. So let me ask you something. How old is the person you are most worried about right now? Whether that is yourself, a parent, a spouse, or a friend. Your answer matters because the same warning signs at 65 are weighed differently than at 75. Tell me in the comments, tell me the person's age, and tell me which of the 6 signs you have seen. I read every comment and your answer shapes the next video. Now I want to talk about what actually drives the brain toward this endpoint because this is where the second great myth lives. The myth, dementia is just genetic, there is nothing I can do about it. The genetics matter, especially for early onset Alzheimer's and for carriers of the ApoE4 gene variant, but lifetime risk is largely shaped by modifiable factors. The Lancet Commission on Dementia Prevention in its most recent update identified 14 modifiable risk factors that together account for nearly half of all dementia cases worldwide, almost half of every case, tied to factors you have at least some control over. The first major enemy of the brain is chronically elevated blood sugar. Researchers now use the phrase type 3 diabetes when referring to Alzheimer's. because the same insulin resistance that drives type 2 diabetes in the body also occurs in the brain. Brain cells need glucose, but they need insulin to deliver it into the cell. When the brain becomes insulin resistant, neurons begin to starve in a sea of plenty. Adults with type 2 diabetes have roughly double the lifetime risk of Alzheimer's, and the damage starts in the pre-diabetic stage years before anyone is formally diagnosed. The second enemy is fragmented or insufficient sleep. While you sleep, your brain runs a maintenance process called the glymphatic system. Think of it as the brain's overnight cleaning crew. During deep slow-wave sleep, cerebrospinal fluid is pumped through the brain at a rate up to 60% higher than during waking hours, flushing out metabolic waste, including the very amyloid beta proteins that drive Alzheimer's. When you sleep less than 6 hours, or your sleep is fragmented by sleep apnea or alcohol or chronic stress, the cleaning crew does not finish its shift. Over years, the waste accumulates. The third enemy surprises people. Untreated hearing loss in midlife is now considered the single largest modifiable risk factor for dementia, accounting for 7 to 8% of all cases. When the brain stops receiving rich auditory input, the auditory cortex begins to atrophy from disuse. The cognitive effort required to follow a conversation also drains resources from memory and executive function, and hearing loss isolates people socially, which removes one of the strongest protective factors. Hearing aids, when worn consistently, have been shown in randomized trials to reduce cognitive decline. If a parent or spouse has untreated hearing loss, addressing it is one of the highest leverage things you can do for their brain. The fourth enemy is social isolation. The brain is a social organ. It evolved to function in the constant give and take of human interaction. When that input disappears through retirement, through widowhood, through children moving away, the brain receives less stimulation, fewer demands on memory, less reason to maintain language fluency. Chronic loneliness increases the risk of dementia by roughly 50%. It is not weakness, it is biology. Connection protects the brain. Now the most practical part. What do you do if you have noticed any of the 6 warning signs in yourself or a loved one? You do not have a 72-hour window the way you do with a stroke, but you do have a window, roughly 12 months. And how you spend it matters enormously because the interventions that work in early stage cognitive decline largely stop working once the disease has progressed to moderate Alzheimer's. There are 6 practical rules. 1. Do not confront the person harshly. Loss of insight, the 6th warning sign, means direct confrontation almost always triggers defensive denial, anger, and a refusal to be evaluated. The disease is doing that, not the person. Approach with gentle observation, not accusation. 2. Start writing things down. Document specific incidents with dates. When did the repeated question happen? What was the missing word? Which familiar place did they get lost in? A written log of 3 or 4 specific events is what a neurologist needs to make a confident clinical judgment. Vague concerns are not enough. 3. Bring a family member to every medical appointment. Patients in the prodromal phase often present better in the doctor's office than they do at home. They answer rote questions correctly, and the doctor sees a confident, oriented patient. The family member is the one who can describe what is happening at home, and many doctors will not ask unless someone is present to tell them. 4. Do not wait for the right time. There is no right time. The biggest regret I hear from families is that they postponed the evaluation by 6 months, by a year, by 2 years, because the person seemed to be coping and the conversation was awkward. By the time they finally went in, the MCI window had closed. 5. Be very careful with over-the-counter cognitive supplements. Almost none have rigorous evidence. Some interact with prescription medications. Some delay the conversation with a doctor by giving the family a false sense of action. Talk to a clinician before adding anything. 6. Watch for safety signals that require immediate action, not 12-month action. If the person leaves the stove on, if they get lost driving, if they forget medications repeatedly, if they fall and cannot explain why. Those are not signs to monitor over the next year. Those are signs that require an evaluation this month. Do not wait. Something many people get wrong. If a few months pass and no new concerning incident happens, that does not mean you are in the clear. It means you were given a second chance and you still need to use it. There are 3 evaluations very reasonable to ask about at your next medical visit if you have noticed any of these signs. The first is a cognitive screening called the Montreal Cognitive Assessment, often abbreviated as MOSA. It is a 10-minute paper and pencil test administered by a clinician. It evaluates memory, attention, language, abstract reasoning, and visuospatial skills. A score of 26 or above out of 30 is considered normal. Below 26 warrants further evaluation. The MoCA is more sensitive to early cognitive impairment than the older mini-mental state examination, and it is the screening tool most neurologists now prefer. The second test is a blood biomarker panel. In the last 2 years, the field of dementia diagnosis has been transformed by plasma blood tests that can detect Alzheimer's pathology with remarkable accuracy. The specific marker to ask about is called plasma p-tau 217. It measures a phosphorylated form of the tau protein that becomes elevated in Alzheimer's disease years before symptoms appear. As of 2025, the FDA has cleared the first of these tests for clinical use in the United States. A simple blood draw can tell you whether the underlying pathology of Alzheimer's is present in your brain. That is a dramatic change from the previous standard, which required either a PET scan or a spinal tap. If your doctor is unfamiliar with these tests, ask them to look into the new Alzheimer's blood biomarkers. The landscape has changed. The third investigation is a brain MRI with volumetric analysis. A standard brain MRI looks for tumors, strokes, and obvious structural problems. A volumetric MRI measures the size of specific brain regions, particularly the hippocampus and the entorhinal cortex, and compares them to age-matched norms. If your hippocampus is significantly smaller than expected for your age, that is a strong indicator of either Alzheimer's pathology or other forms of degenerative dementia. If sleep is part of the picture, if the person snores heavily, has been told they stop breathing at night, or acts out vivid dreams, a sleep study should be on the list. Untreated sleep apnea triples the risk of dementia and is highly treatable. Stepping back. Dementia is not a lightning bolt from a clear sky. It is a predictable event that comes after years of silent brain change, and it announces itself in the 12 months before diagnosis with very specific signs. You now know the 6 big ones. Trouble with familiar multi-step tasks, repeating questions or stories within minutes, word substitution, getting briefly lost in familiar places, personality flattening and apathy, and loss of insight when the topic is raised. Any of these showing up in yourself or a loved one is a reason to talk to a doctor and ask about a MoCA, a plasma p-tau biomarker panel, and a volumetric brain MRI. On the prevention side, keeping blood sugar in a healthy range and catching pre-diabetes early protects neurons from insulin starvation. Getting 7 to 8 hours of high-quality sleep lets the glymphatic system clear amyloid each night. Treating hearing loss with hearing aids preserves auditory cortex and protects against social isolation. Building genuine social connection, especially after retirement, gives the brain the stimulation it evolved to need. And the most important thing to internalize: do not wait for the signs to become impossible to deny. By that point, the 12-month window has narrowed. The earlier you act, the more options remain. The most painful conversations I have with families are the ones that begin with the words, "I knew something was wrong 2 years ago, but I told myself I was imagining it." Everything we covered today is for your understanding and education. Your situation is specific to you, and using this as a starting point for a real conversation with your doctor will always be more useful than trying to manage things on your own. If this made a complicated topic easier to follow, subscribe and hit like. That is how this channel gets closer to that goal of 100,000 subscribers. And if you want something practical to keep on your phone, the link in the description below has the dementia screening checklist and the questions to bring to your doctor. Share this video with a parent, a spouse, or a friend who needs to see it. Today, not tomorrow. Because every one of these 6 signs is easier to act on while there is still time to act.